Bonjour, my name is Xavier Leleu. I'm professor of hematology, expert in myeloma, and I work in the city of Poitiers in France. I'm a member of the IFM and board of director of IFM, and the IFM has Intergroup Francophone of Multiple Myeloma has a long time ago in 2010 been one of the first cooperative group scientific society to launch and develop and try to find the best use of Pomalidomide and Dexamethasone back in the old time, second in class IMiDs. So back then, the IFM had launched an IFM 2010-02 phase 2 study in high-risk multiple myeloma in the relapse setting, first relapse. So we had looked at patient deletion 17p in first relapse, Len exposed, and certainly back then Len refractory, and similarly with translocation 414. Patient could have either or the two abnormalities, one of the two or the two abnormalities. And on pomalidomide dexamethasone, remember it was in 2010. Today it would be bizarre to do that, but in 2010 it was a way to go. And in 2010 we found out that the median time to progression, primary endpoint of that study for deletion 17p was 7.3 months, which would be considered as extremely disappointing today. But again, in 2010 it was a result. And however, for the translocation 414, it was 2.8 months. And definitely this was considered back then and would be considered today as really a poor result. So we question how to improve the pomalidomide dexamethasone, and I am going to report on the IFM 2014-01 Ixazomib pomalidomide dexamethasone in relapsed refractory multiple myeloma characterized with high-risk cytogenetic. Same high-risk cytogenetic definition, deletion 17p and or translocation 414. Similarly, line 2, and the patient were to be Len refractory, and they could be proteasome exposed, but in no case proteasome refractory. The deletion 17p or T414 definition was as usual in my group, and either known at diagnosis or not known at diagnosis, but discovered at the time of the relapse. So primary endpoint is again time to progression, and the objective is to double up the median TTP for the two groups, knowing that for deletion 17p, knowing we were at 7.3 months, we would expect something like a 14 months. And for the translocation 14, we would expect something like 5 months. So we did give Ixazomib pomalidomide dexamethasone. Ixazomib was given on a sort of a bit dose dense way, 3 milligram twice weekly, 1, 4, 8, 11, and after a number of cycles, sort of maintenance, 4 milligram weekly. Pomalidomide and dexamethasone were given as usual, pomalidomide 4 milligram. However, cycles were initially 21 days long, and when we reached the maintenance phase, it was 4 weeks long. There was 17 cycles, so 3 weeks long, and then thereafter until progression, 4 weeks long for the remaining treatment. So we started to recruit in that study, and we very rapidly had recruitment issues because it was difficult to recruit high-risk multiple myeloma on Ixazomib pomalidomide dexamethasone, although in parallel we had other very interesting, particularly anti-CD38 monoclonal antibody combined regimens available for these patients. So we had to change our plan. And initially, we planned to recruit something like 70, 80 patients on the basis that we would analyze separately deletion 17p and T414. In the end, we have recruited 26 patients, and these 26 patients are sufficient to answer the question if we do not split T414 and deletion 17p, and look in intention to treat at the entire cohort and analyze the entire cohort as one. The median age was 72 years old, ranging from 67 to 78, and globally, 10 patients had deletions in P, 12 had translocation, 414 all refractory to lenalidomide, and globally, the median TTP was 9.7 months, which is disappointing because we are in line 2, but in the end, not necessarily a bad result if you think that we are in high-risk multiple myeloma in the relapse setting, len refractory, all of them, and not necessarily many other combinations do better these days. The median overall survival was 12.2 months, and in the poster presented at IHA, you had the response rate, etc. We cannot compare deletion CNP T414, and we are not going to do so. However, it is expected that the translocation 414 have enormously improved with the addition of Ixazomib to Pomalidomide and Dexamethasone compared to the deletion 17p that are probably disappointing, and maybe that triplet-based regimen is not the optimal regimen for this deletion 17p high-risk myeloma profile in the relapse setting. The safety profile was a safety profile known for Ixazomib, Pomalidomide, and Dexamethasone, and I'm not going to conclude on that here. So the conclusion of our study is that we report for the first time the results of that study. At ASH this year, we'll report more of that study in efficacy and safety. Here, we essentially reported on the safety and the descriptive part of the population. We think Ixazomib, Pomalidomide, and Dexamethasone was very nicely manageable, very nicely appreciated by the patient, entirely oral regimen, triplet-based in relapse setting. It was active in len refractory. Globally, the data will need to be confirmed, but definitely we need to be improved. We agree to that, but clearly it's an option for many patients that would want to have a triplet-based regimen and potentially including the high-risk myeloma. More details on whether T414 or deletion 17p and the feeling that the T414 have had a great benefit to this treatment will have to be awaited. Thank you very much.